And Ali Velez, take it away.
Thank you very much, Tom, and everyone. Good afternoon, good morning, and good evening from wherever you are accompanying us. I am happy to be here as a biomedical engineer and technical focal point for the Oxygen Access Scale-Up Initiative since June last year. So I will be sharing with you what it has been the experience from the technical perspective of this initiative. Next slide, please. So as we have been discussing during all the last months and years, even the scaling of access to medical oxygens require a multidisciplinary effort and different aspects and topics to be where some of the colleagues here are defending or are advocating or are doing new work on with regards the scaling of the access. As I said, I will be focused in the technical solutions that we have been proposing or we are working with the countries. The ultimate goal of all of us is to increase the quality of oxygen that reach safely the patients. And this means that we'll reach the patients along the health cycle of the health systems, meaning all ages, all patients that will be in the need. And it's a continuous and evolving cycle. Here I put the life cycle of the medical devices or the health technologies, but the idea is that these cycles will also follow the cycles of any medical intervention and accompany from the assessment and analysis of the needs up to the monitoring and evaluation of the devices that have been implementing. Next slide, please. We have been also discussing that to understand the oxygen ecosystem from the technical perspective, we have been separated in three main aspects: the oxygen sources, the distribution systems, and the delivery systems. The idea is that the three of them reach the patients in an equitable way and at the right time and in a more sustainable way, that the action is sustainable, so that requires resource allocation, building local capacity, and in some situations understanding at cultural level and policy level that there is a need for oxygen. And it requires a multidisciplinary stakeholder action. And that's why we are here with all of the partners to develop strategic planning tools, advocacy, and technical support. To start building the tools and to start building the strategies to support the countries, one of the first things that we do, it was to understand what is the humanitarian procurement with relation to the medical equipment. And this topic is some of the topics very well known by all of us as biomedical engineers. There are some studies, I didn't put the reference here, but some articles where Gabby Jimenez, one of our biomedical engineers, has been also writing that there is estimates that between the 40 and 70% of medical equipment either procured or donated to the low and middle income countries are inoperable. There are many reasons for this to happen, starting from the lack of need assessments or inventories, but also the inappropriate selection of products, maintenance, trainings, and incompatibility with the infrastructures. Along the cycle of the health technologies that are basic for the health interventions, the persons that are in charge of doing this is the biomedical engineers or biomedical technicians on the field. We know that in most of the countries where there is no formal education, this is also done by other technicians that have been receiving the informal education, that they were electricians or plumbers. And so the idea of this is to show that we need to merge the knowledge of all of these different technical families. In some field visits that we have done, we have been taking these pictures that you can see that a lot of equipment arrives and it's just there like in a storage room, or that is just there like a museum because they are very old or there are not manuals, etc. So we want to raise awareness that this is happening, and this is still happening after many years that it has been said that, the donations and procurement hasn't been done, taking into account that the biomedical engineers should be in all the cycle of the decision making. Next slide, please. Yeah. So understanding this, we also tried to find out what were the guidelines or guidance that has built inside WHO, but also in other countries or with other partners with relation to the oxygen systems. So here there is a beautiful timeline that shows when the discovery of the oxygen as an element was done, up to some country policies, clinical guidance, and work done with other stakeholders. Go to the next one, please. Here is the work that was done during the last year. As you can see, it likes multiplicate a lot. And this is just showing what has been done mainly with WHO and some other partners, but there is a lot of work doing by partners that is not reflected here. And we also have been trying to collect the information to make it publicly available. Some of the main publications that we have from April last year, it was emergency supply, global supply chain catalog that, you know, it supports country to buy equipment related to the COVID response. We have also the ESFT tool that now is in version 4, that it's helping at national level to forecast what will be the needs starting from a 0 point for all the equipment related to laboratory, PPE, and oxygen, related also to COVID. And we have also and we start the PSA technical specifications for for procurement. We have also the priority medical devices, and we will go through details of some of them. Next slide, please. So one of the first action was this priority medical devices list that Adriana also explained. So I won't go into much detail, but this was one of the first approach that we had as a team to understand. We first need a list, then we need to study the market. That was done with other colleagues here. And we know that since last year, there has been a lot of market constraints to get access to these equipment. We need to understand what is the context where they are going to be used and what is the holistic approach that we will do to implement. That means to build the bundles, consumables, spare parts, and accessories, to quantify them. This was done also with our clinical colleagues. So we can send the equipment with the complete devices that they need to be used and operable as soon as they reach the countries. Next slide, please. Other actions that we took in relation to the oxygen access scale-up was to run 4 sessions for technical consultations with our implementing partners. Some of them are present in this call. And the objective of these consultations was to identify the gaps and challenges related to the oxygen ecosystem, but mainly to the technical requirements that the oxygen generator plants and the liquid oxygen needs for being implemented or the systems in the low and middle income countries. As an outcome of these consultations, we could see that also work started to be done in parallel with also other departments in WHO, like the modification of the International Pharmacopoeia to include the Oxygen 93. And there is also work ongoing related to the good manufacturing practices of the oxygen. And we know also the Oxygen Task Force get together, trying to advocate and get funds for the oxygen implementation. Plus, I think one of the things that we are working now, and it will be of high impact, and we would like to have collaboration of many of the experts on the field, is the interim operational guidance for the oxygen generator plants, pipeline distribution, high pressure gas cylinders, booster compressors and filling stations and distribution manifolds. We are trying to cover all the cycle for the implementation of the systems, from the strategic planning, procurement, commissioning, operations, and even the commissioning of the systems. This was a result of the discussions trying to understand where the bottlenecks, where were the needs, where the standards are affecting or supporting the systems. We know, for example, I put here one about the piping that maybe some of the colleagues will talk after, but we found out that the standards for piping are very old and they are not applicable for low and middle income countries. And we have, as commonly, few reference only for UK or from the US that are not applicable in some of the contexts we work. Next slide, please. Then the question was how to bridge the gap between all this technical guidance that has been there and the real implementation. Do we have enough biomedical engineers, enough resources to implement what has been theoretically planned? Are there enough guidance actually that are applicable for low and middle income countries? And then we start working with some practical actions. Next slide, please. And we start with some field visits and with some direct assessment to countries. Here I just put some of the steps that we do to understand the context and the need gap identification related to the oxygen ecosystem. So as you see, first thing we need to know is where are the sites located, where is the geographical location, the geographical distribution of the existing capacity. Even for the design of the system, we need to know what is the altitude, the elevation, the area, the catchment area, etc. We need to understand how are the roads, because some of the problems of access is actually how to decentralize the oxygen from the big hospitals to the health centers. Once we are in a health facility, also we needed to understand how is the distribution in the health facility, if there are modular hospitals, if it is if there is good ventilation, if there are good roads to move the cylinders, etc. What are the IPC measures that are on the systems? Because we know all the equipment needs also some maintenance, and there is also some risk for the people using and maintaining it if there is no good IPC measures inside the hospitals. What are the energy sources? What are the accessories, the compatibility of these accessories to other biomedical equipment? So we are trying to understand from a holistic way what is the situation in each of the health facilities that we would like to assess. And from there, we calculate or we propose what is the need gap and where is the bottleneck or what we need to start solve to assess the health facilities. And normally it will be related either to the equipment, to the training, maintenance, or power generator. Next slide, please. We also start to work in sharing the decisions and accountability in the procurement process at all levels, meaning from HQ here to the regional level and to the country, to the work that we do directly with the countries and the MOH. We start trying to communicate and to show how the biomedical engineers need to be involved along the cycle, from the needs assessment, to develop the specifications, select the equipment. In part of the procurement, it has been very interesting to work here with our colleagues from the logistics, because there are many things that needs to be rethought. Once in the shipping, you need to decide how to put the pallets, how to name the equipment so they can pass the customs, etc. So we have been working with the procurement and logistics team. After that, when the equipment arrives, where it will be with storage, how it will be distributed along the health facilities, installation, and the maintenance, as we know. We have been also working in parallel with the equipment that is already there, trying to train on the rational and safe use of oxygen, trying to do the inventories, as you know, and trying to document what are the local prices and what is the health workforce in each of the facilities. Next slide, please. With regards to assessment of the oxygen need gap, specifically for estimation of the oxygen demand per facility, we are also working on this because there are different approaches and we have been learning on the way also and contextualizing our solutions. There are different ways to apply the usage factors. There are some calculations that are according to number of beds, bed occupancy, hypoxemia rates, average flows, the number of cylinders, the number of outlets, or the distance of the hubs of oxygen to the different facilities that they want to serve. There is no one rule to do it, and that's the reason we haven't developed a calculator that is publicly available, because there are many things that we need to consider and combine to come to a solution that will be fitting the context. Next slide, please. We have been, as I mentioned, and we emphasize this a lot, we have been trying to have a holistic entire approach. So selecting the solutions, bundle the solution, and cost, making an estimation of cost of all of it. This is representing what it's in general, what is including, what should be implied when we want to procure a PSA plant. I forgot to put the shipping. That is one of the cost drivers of these big devices. Once we have the costing of everything, then we unbundle the solutions to see what it will be, where do we start? Do we start with the power supply? Do we start with the trainings? Do we start with the maintenance of the existing PSA plants, hiring some operators and biomedical or drivers or human resources in general? Do they need service level agreement for the existing plants with international suppliers, etc.? And then all of this is represented with, it's divided into the capital cost of the equipment and operational cost. So we are trying to also increase our bank of costs so for the negotiations with the suppliers in the future. Next slide, please. We are trying to put all of the information that we have been developed and the partners are developing and has been done even before the initiative in the website. So the website was finally launched last week. The objective is to integrate the guidelines developed with the different departments inside WHO, so meaning the medical devices department, the clinical guidance, the innovation team, and also to connect with the partners' publicly available tools like the PAD or EBC, and to put the WHO tools that we are developing, and we want to also cross-check with the partners to be updated with the news and the webinars that we are doing with all of you. Next slide, please. And these are basically the tools that we have now, and they will be uploaded. They are under review. So it's the Rapid Biomed Inventory tool that since last year it was developed, and this has also a group of pictures that will help the people to follow. And everybody that has done an inventory know how difficult it is to be catching like the model of the equipment, the serial number, etc. It's not something easy to do. So we try to make a rapid assessment tool with pictures, so for the engineers and technicians on the field to know their existing capacity. We have also the facility assessment tool to estimate the oxygen demand. That, as I said, we haven't put a calculator because of the reasons and different considerations around it. We have the assessment of liquid oxygen supplier. Yeah, it's almost the assessment of existing oxygen generator plants for maintenance, technical requirements to procure oxygen generator plants, site evaluation and preparation, which is very important because of, as I said, the size of these devices require a lot of planning before procurement. The holistic biomed bundles, and some of the work done with the clinical team is the home care bundles, the rational use of therapeutic oxygen, the training videos that has been done with the Adriana and Priyanka, and the oxygen fire risk mitigation measures that we put in 3 posters. So you can access to the website and look through them. Next slide, please. And yeah, so I wanted to close with this slide. So knowing that the health technologies are needed along the health system, as well the biomedical engineers are needed along the health system to maintain, to procure, to choose the correct equipment. So the proposal is to, again, bundle and cost what are the needs to increase the human resource capacity at field level, and then unbundle the solutions to start working with different areas, like maybe building a policy for for them as health workers, or workshops, or bringing programs for the universities, for the technicians and the engineers. So over. Sorry, I think I passed the time.
Thank you, Ali. A bunch of great information, that I know a lot of it's late breaking. You've been working on it for months, but you've just published it at that site you were talking about.